Okay, so we want to welcome everybody today to our Family Medicine Grand Rounds presentation. It is a special week with Primary Care Week happening this week. Today is October the 6th. We do have a new CME reporting system, and so I will walk through some steps here to help everybody with that, but the event code is a new 8-digit code. In order to first register, you'll need to send your email address to the number listed there. I'll put the information in the chat box as we get going as well, but you'll send that 8-digit code once you've registered. You'll text attend and then the code, and you'll want to make sure you do that before midnight tonight. So I'm going to go to the next slide here. Let's see, give me 1 second. There we go. So this is the new system. And you can see over on the right-hand side that you will text your email address to that toll-free number. And then from there, you can text the word attend and then also include the 8-digit code. But if anybody has any issues with that or any questions, I'll put my email address in the chat box once we get going, and I'm certainly happy to help with that. We want to thank everybody as we get started here. Please make sure that your microphone is muted. Also, if you would remain attentive to the presenter, engaged in the session. And then also I will be putting in an evaluation link. If you could please help us out with the evaluations, not only for our presenter, but also for our Grand Round sessions. And let's see. This is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central Area Health Education Center. CME transcripts are available. So once you register for that CME, if you are wanting to see your transcript, which you will need that transcript for AAFP credit to submit for that, but you can visit the CME website there to view your transcript. And then the AAFP credit, you'll send that transcript to them so that you can get your credits for the presentations. But if you have any questions, please feel free to contact me. We do want to make sure that we let everyone know that it is our goal to cover these core competencies. So those are listed there for you. And I will now let Dr. Hyen, he is the chair of our department, I will let him go ahead and introduce our primary care guest speaker.
Well, good afternoon all, and happy Primary Care Week. I'm excited to be here and to, this is the Byrd E. Bellue Senior and William Richmond Holly Senior Distinguished Endowed Lecture Series. It was established in 2012 through a generous gift from James L. Holly and Mrs. Caroline Holly to honor their fathers by advancing primary care at our institution through educational collaborations. Annual distribution from this endowment are used to promote and disseminate best evidence for the benefits of advanced primary care models, inspire medical, nursing, and physical assistant students to dedicate their careers to provide advanced primary care, and engage in network students, family medicine, medicine in pediatric residents, and advanced primary care nurses with practitioners and researchers developing innovations in advanced primary care. I am delighted that Dr. Alice KRist is the 2021 Bellue-Holly Distinguished Visiting Professor. Dr. KRist is a professor of family medicine and population health at Virginia Commonwealth University and a practicing family physician at the Inova Fairfax Family Practice Residency. He directs the Virginia Ambulatory Care Outcomes Research Network, ACORN, a collection of over 500 primary care practices that partner to conduct research that matters for primary care. Dr. KRist is a former member and immediate past chair of the U.S. Preventive Services Task Force, where he was from 2014 to 2021. His personal research interests focus on implementation of preventive recommendations, patient-centered care, health equity, shared decision-making, health information technology, and practice transformation. On a personal note, Dr. KRist is a wonderful family physician role model and collaborator, and a brilliant person who is very humble and really provides great fuel for advancement of primary care. So Dr. KRist, welcome, and we welcome you to our lecture.
Thanks so much, Carlos. I really appreciate the opportunity to be here today, and to talk during Primary Care Week. So I'm going to try and talk today about designing and implementing high quality primary care. And I'm going to put a disclaimer up here because I'm going to draw a lot on today from the recent National Academy of Science, Engineering, and Medicine report on implementing high quality primary care. And I'm also going to draw some on some work that the U.S. Preventive Services Task Force has been doing. So a lot of the stuff I'll present is work that other people have been doing, and they need to get credit for that work. I'm going to try to talk a little bit beyond just the reports and talk about what I think they mean and where some of the directions of primary care and family medicine may go for the future. I don't have any financial conflicts of interest to declare. So as I said, we'll talk about this National Academy report. We'll talk about task force methods, specifically around issues related to equity and getting high access care to everyone, and then think a little bit about a future vision. So as Carlos mentioned, I direct our practice-based research network, ACORN, and we have nearly 500 practices in the network, and they span the whole spectrum of primary care in Virginia, include every health system in Virginia, small single doc offices, large multi-specialty groups, a little bit of everything. So some of the learnings I'm going to talk about really have been created by these folks that we work with. And then here are all the different investigators on our team. So we have a really nice multidisciplinary team that I'm very lucky to draw from. So once again, it's going to reflect a lot of their work. This is the type of stuff that we try to do. COVID's taken a forefront, equity, social needs, but we've always dealt with prevention, health information technology, how to improve evidence-based care and practices. So I'll talk a little bit about that here today. To begin with, I'm going to set the stage about the state of primary care in Virginia. And I want to be clear because I think that the state of primary care in Virginia, probably it's pretty similar in Texas and pretty similar in most states. And I'm going to show you that Virginia is pretty average, but it shows you the scope of what primary care is addressing. And we were able to do this evaluation as part of our Medicaid expansion. So in 2019, Virginia was the most recent state to do Medicaid expansion. And in the pandemic, where the number of uninsured people went down nationally, Virginia actually went up. So it's been really protective in Virginia. I know that there's been pushes in Texas for Medicaid expansion and it hasn't gone through. But I can tell you from what I've seen in Virginia, it's made a difference. But our state wanted to fund us to say, how is primary care doing and can they handle Medicaid expansion? So we had an opportunity to go and identify every primary care doctor in the entire state and to actually survey all their practices. So we've been putting a lot of effort into this. And what we see is that in Virginia, we started with looking at claims and their license designation, and then are they active clinicians and do they do wellness, which we thought was sort of a primary care specific diagnosis code. But we find in Virginia that there are 5,889 primary care clinicians. And that puts us dead in the middle of all the states in terms of the number of primary care clinicians per capita. We're ranked 25 out of 50 states. And there's about 83 primary care doctors for every 100,000 Virginians. And for every person in Virginia to have a primary care doctor, that means every primary care doctor in the state needs to have a panel of 1,225 patients. And we know that's not the case. Not everyone's working full time. But this does give us a little bit of a clue that we think that we're doing okay with primary care workforce in Virginia. Below is some interesting numbers. So this is sort of the distribution of primary care. And that bottom line is clinicians who had at least 10 wellness visits. But you see, we have 5,899 primary care doctors. We have 21,000 specialists in the state. So there's a big misbalance with this. In family medicine, fully about 25% of the family physicians actually didn't have 10 wellness visits. I don't quite know what that is. That's actually some of the work that we're doing right now to try and find out if they're really practicing primary care. We believe most of them are, but we tried to give credit across internal medicine, peds, OBGYN, and even our specialist colleagues, thinking that there may be some cardiologists in rural communities who dual function as primary care in addition to cardiology. Although you'll notice there's only 29 of the 9,000 specialists who meet that criteria. This is the distribution of primary care. So this is every practice in our state. And we find we've got a pretty good distribution in some of the rural communities and the lower SES communities. It might be a little bit lower, but it's not a bad distribution here. But we had some concerns with our workforce, and this was pre-pandemic, and it's probably gotten worse. We're updating it right now as we speak, actually. But in 2016, only 40% of Virginians saw a primary care clinician. So here's this gap of people having what we think of as a primary care home. The other thing that we saw is that our workforce is aging. So 20% of our primary care clinicians were over 65, yet only 12% were under the age of 40. So that gives us a little bit of fear for the future. And then, of course, we have a little bit of an issue with the distribution, as every state has, with where the clinicians are located compared to need. Now, here's some of the impressive things about primary care in Virginia, and I think this probably reflects nationally, is that our practices say that they're doing a lot to try and address access. So here we are pre-pandemic, 1 out of 5 practices already had telehealth, and we went up to virtually 100% with the pandemic. They're trying to get patient portals, on-site basket of services like radiology and lab, expanded hours, same-day appointments, 24-hour phone access. So I'm at a residency and we think that's normal, but to hear that 73% of our practices in the entire state have that, that's pretty good for access. Mental health is a big concern for Medicaid expansion. So we looked at how much is primary care doing mental health. And there's a lot of features that primary care is telling us that they have in terms of integrated behavioral health and primary care, where they're working with mental health providers, exchanging information, providing mental health themselves, addressing substance misuse, and addressing unhealthy behaviors. So pretty big scope of practice for primary care. And then more and more, we're talking about addressing social risks. And obviously with Medicaid population, this was important. And looking across various social needs, primary care is trying to address difficult topics like financing, transportation, housing, health literacy. Some of these topics they're dealing with better than others, and I'll talk a little bit more about this later on. And then this was one of the concerning things, is that 1 out of 3 of our primary care practices in 2018 said that they had a significant practice change. So that's the blue bar. And the orange bar was in 2018, 2019, them saying, well, what's going to happen the next year for stress? Well, we knew that blew up and got a lot worse. They were all pretty optimistic that the next year was going to be better. But as I said, about 20-30% of practices had some major stress like clinician turnover, selling their practice, switching electronic medical records. So there's a lot of change going on in primary care. This is what happened with Medicaid expansion. So Medicaid was offered to any individual with an income of $16,000 or less, or families with a household income of $28,000 or less. And they got 500,000 Virginians to sign on to Medicaid with this, which I find a little frightening, because $28,000 for a family income in our state is pretty difficult to get by on, but that was the eligibility for this. And what that means is that right now in Virginia, 58% of our practices have at least 10% of their patient panel of patients have Medicaid. So Medicaid is an important insurer as our practices are thinking about caring for their patients. I'm going to use that as a transition where we've sort of talked about what's the state of primary care in Virginia. I think it's somewhat reflective nationwide. And let's talk about the National Academy of Medicine's report on implementing high quality primary care. And there's a link on this slide. You can go to this link, you can download the report. It's 500 pages, so it's a long report. There's a lot of meat and a lot of details in there, but I'm going to try to tell you a lot of what it means. There was also a wonderful article in JAMA by Bob Phillips that highlighted the overall report. And then just recently, an article came out in the Journal of the American Medical Informatics Association that talked about the digital health elements of this report. So the report opens up with talking about the value of primary care. And one of the first things to put in your arsenal as you're talking with payers in your health system and others is that primary care is the only part of our healthcare system that has data showing that it extends the length of life and promotes equity within communities. That's critically important. And unfortunately, primary care is weakening right now when we need it most. You know, post-pandemic, and as we're dealing with access and sequela of the pandemic. The share of total healthcare spending on primary care is also going down in most states. So this is a problem. And we know that the pandemic has amplified economic, mental health, and social inequities. And these are some of the things that actually primary care deals with. And at the same time, the pandemic has made things worse for primary care. So we've had a few of our practices in the state close. We've had some clinicians decide to retire or phase out of their careers at an earlier time than we would have otherwise. But the bigger problem that we're seeing in our practices is actually getting staff. So nurses and other support staff to try and help primary care practices, which is so critically important. So here's a slide that scares me in the report, and this is the number of visits versus expenditures. So what you see here is that primary care does 35% of all of the ambulatory visits in the nation, and we only get 5% of the healthcare spend. So this is a big inequity in terms of how we're investing in our healthcare system. And I'll tell you that this is different in the US versus other developed countries. So the graphs don't look like this in other developed countries. Most other developed countries actually have 10 to 20% of their healthcare expenditure on primary care. And a lot of the excess expenditures go to hospitals. I think you all are with a hospital. I'm with a hospital. They're important. We need to protect our hospitals, but a larger part of payment is going there. A larger part of payment is also going to pharmaceutical benefits. And so we need to be working towards more payment towards primary care. This is really important. So this report was building on the 1996 report. And this is the 1996 definition of primary care. And for the past 2 decades, I've been using this definition when I go and I talk and I think about primary care. And it says primary care is the provision of integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with patients, and practicing in the context of family and community. And this is a great definition, but the committee decided to update the definition. And I have to admit, I think this is a greater definition of primary care. And now what we say is that high quality primary care is the provision of whole person, integrated, accessible, and equitable healthcare by interprofessional teams that are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships with patients, families, and communities. Now, the things that changed here is the 1996 definition was much more about people and specifically clinicians. This is much more about the delivery of services by an interprofessional team. So it's more about teams, it's bringing that out. It's bringing out the function of primary care as opposed to the person. It's stating very clearly that primary care delivers the majority of a person's health and wellness. I think that's an important message there. It's building on the relationship, and it's talking about the longitudinal nature of that relationship, and not just with individuals, but with individuals and families and communities. And I think these are important things to be thinking about as we think about primary care. Here was something that I learned on this committee, and that's common good in this definition. So if you read the report, it makes a very important statement that primary care is a common good. And we talked about this for the first 2 or 3 committee meetings, and there were some smart members on the committee who really understood what we were meaning when we said this. And it took me a little while to really figure out what this means here. And I put the definition from the Stanford Encyclopedia of Philosophy. So a common good are things like electricity, your rescue services, police services, your water services. And what it says is that in ordinary political discourse, the common good refers to those facilities, whether material, cultural, or institutional, that the members of a community provide to all members in order to fulfill a relational obligation they have to care for certain interests that they have in common. So being able to advocate that primary care is a common good is extremely important. So it's saying right off the bat, it has high societal value. And that means that we need advocacy, leadership, and public awareness to support and promote primary care and to make sure that it's resourced the way it should be. So let me get into the 5 objectives that came out of the report. And now I'm going to start relating these objectives back to some of the research we've been doing in Virginia and some of the work that the U.S. Preventive Services Task Force and other groups have been doing, and talk a little bit about what this means for the future of primary care. But we tried to get 5 simple objectives that people could say quickly to people about, well, what does it mean to implement high quality primary care? What are you asking? So one of the first is to pay for primary care teams to care for people, not doctors to deliver services. The second is to ensure that high quality primary care is available to every individual and family in every community. The third is to train primary care teams where people live and work. The fourth is to design information technology that serves the patient, family, and interprofessional care team. And then lastly, to ensure that high quality primary care is implemented in the United States. And that's really about putting leadership in place and a scorecard with measurable objectives to make sure that we can say that we're meeting the goals that we've set. So let's kind of break this down. We'll start with the first one about paying for primary care teams to care for people, not doctors to deliver services. So there were 4 parts to this recommendation. So the first is that payers should evaluate and disseminate payment models to promote the delivery of high quality primary care and not short-term cost savings. So this is very important. If you remember back to the Affordable Care Act, and people were talking about prevention, one of the things that people talked about is, oh, preventive care will save money. And that's the wrong message. Any type of healthcare actually costs money, and we're actually asking to spend more on primary care. So the issue here is not let's pay for primary care to save money. It's let's pay for primary care because this is high value for our dollar. So we get the best return on our investment in healthcare dollars by investing in primary care. The second action is payers using fee-for-service models for primary care should shift more to hybrid reimbursement. And a big purpose here is to build the infrastructure of primary care, to not have it be about that one-on-one relational individual encounter, but to really be about taking care of the majority of a person's health and building the team and the infrastructure that you need to do this. My groups participated in a number of value-based programs, and I don't know what your experience has been, but for us, when we do this, what happens is we agree to do something, and then we have to put all the investment into doing it. And at the end of the year, if we've done a good job, the insurance company blesses us with extra payment or not. So all the risk is put on primary care, and all of the investment and development is put on primary care. And since it's already the lowest paid part of our healthcare system, that just doesn't make any sense. And then CMS, through its portfolio, should increase primary care spend, and states should try to bring these multi-payer collaborations together so that we have more alignment across payers and not a separate program for each individual payer that we have to try and figure out how we're meeting. So here are the goals of the actions. Ultimately, pay more for primary care, resource primary care to proactively build infrastructure, not reactively, pay for teams. This isn't just a clinician seeing a patient, and pay for collaborative care with communities. So some of the implications of this, I think one is for the future, we need to be thinking outside of the walls of our offices and more broadly about what the team is. So this is my triangle when I'm a clinician, and a lot of our clinicians just live in this triangle. And that triangle is the nurse's station, the exam room, and their office. And at each corner of the triangle is a computer that they spend most of their time typing in. But this is where patients live. And this is where most of the things that affect their health occurs. Or if they're in a rural community, this is where they live. And so how do we get healthcare out into these areas? And thinking about payment, part of it is actually to pay for care in places where people need it and by team members where people need it. This is a study that we're doing right now where we're trying to think a little bit differently about kind of being proactive in care. And we're calling it an enhanced care planning, where we're identifying patients with more than one chronic condition that's uncontrolled. And we're trying to do 4 things for them. We're trying to get them to do a systematic health risk assessment, which we call My Own Health Report. And through that, they create a care plan. If they have a risk, they say, I want to work on this and try and improve it. And this is how I want to do it. We're creating a patient navigator. And I know you have some patient navigators, which is wonderful. And some primary care practices have this, but this is sort of the clinician anchor to help a person. And then we're linking them to a community health worker who can help a person bridge the healthcare resources and the community resources to achieve their care plan. And as part of that, we went through and identified all the different community programs where we're having this occur. And just in the Richmond area for 23 health, behavior, mental health, and social needs, we actually found 900 different community programs to help people. And so trying to know those programs and link people to those programs, that's a big ask. And you can see how when you're talking about building systems to care for people, this is reaching out to multiple care team members. It's reaching out to multiple entities across the community and learning how they can work together. And this is roughly the care planning process for a patient, where they'll go through and identify their risks. They'll pick 1 or 2 to make a plan on. They'll tell their story on why they want to make a change. They'll make personal goals. They'll select evidence-based actions. And then throughout, they'll track their confidence on achieving their goal. And it's fascinating. We're into the first 100 patients enrolled in this. And, I thought a small number of patients would utilize the community resources, but we've actually found it's about 70 to 80% of people want to be connected to various community programs for assistance. Here's another thing when thinking about payment that's going on in Virginia that I'd advocate you might want to think about trying to push in Texas. Our governor pulled together a task force on primary care to say, how can we build primary care and to make sure that it can deliver the care it needs and be sustainable? And they're defining the success of primary care in this task force of, can we get clinicians and payer to have a better relationship? That'd be amazing. I don't have great relationships with our payers, other than with our Medicaid office, who's actually helping to fund a lot of the work that we're doing. How do we make primary care services accessible? How do we make it a positive primary care practice experience for clinicians? How do we make sure primary care is viable and safeguarded? And then how do we promote innovations like telehealth and not go back on some of the things that we've been advancing over the years and more recently with COVID? So let's talk about the second recommendation. This is assuring high quality primary care is available to every individual and family in every community. So baked into this is quality and quality improvement. I'm not going to talk about that as much. This is things like your alerts and reminders for evidence-based care. I know you have Epic, so this is your care gaps and making sure people are up to date. This is using your registries to reach out to patients and make sure you're delivering the care that you want. But there's a whole new level to this high quality care that I'd like to, and access that I'd like to talk about. So here are some of the steps. So first, payers should ask all beneficiaries to declare a usual source of care and to really form ongoing relationships for the uninsured that they treat. Now, I lived through the years of managed care. I'm a little bit skeptical about declaring a source of usual care. I think there's a lot to go with relationships on this. But I think the concept here is really making sure that people have a home and that they know where their home is for primary care. The other is building new health centers in rural areas, in health services and other shortage areas. And then having CMS revise access standards for Medicaid and Medicare beneficiaries, permanently supporting COVID-era rule revisions. And if Texas is similar to Virginia, a lot of these are starting to go away. We had payment parity for telehealth, and we're starting to not get that. We're starting to get insurers tell us that certain visits can't be done by telehealth, and we're starting to have a lot more of the rules about practicing outside of state boundaries without getting licenses in every state. And that's going to be a big barrier for telehealth. And then primary care practice should include community members in governance, design, and delivery to partner with these community organizations. So I want to talk about some of the implications that I see for the future, kind of going another step on access. So a big part of this report was trying to make sure that everyone has access to primary care and that people are not falling through the cracks. And so we're pretty good about using our registries and saying, oh, such and such hasn't come in for an annual wellness visit, but we're not as good about finding people who aren't coming in. So this was an exercise we did for our 12 practices. We see about 185,000 patients in this one primary care group. And the first thing we found is that we had patients living in every single state. That was kind of surprising. And I'm sure this includes college kids and other people. But if we go back to that longitudinal relationship, this may be important to think about how do we maintain that. But if we focus in on our 70% service area, that's where most of our patients live, we actually have about 144 census tracts of people that we care for. And what we've been doing now is we've actually been using our state's all-payer claims database. And then we've been using the census data, and we've been using social data and other data about communities to try and understand our communities that we're caring for better and to look at what their needs are and the types of things that they're struggling with. So you can see in that red box, these are the type of data elements that we're combining. It's everything from workforce to healthcare delivery, the physical, social environment, social economic factors and policies and spending, and how does that influence the health of the community? And then we're using our claims data to say, okay, we know who we see, but who are we not seeing? And who's not being seen in total? So as an example, we try to identify folks who are showing up to the emergency room or the hospital for chronic conditions or for primary care preventable illnesses who haven't been seen in primary care. And we're trying to think about how do we reach out to these communities and better address them. Now, a placeholder for you in Texas, there's been a couple initiatives to put together an all-payer claims database back in 2014 and 15. They didn't get funding, they kind of fizzled. Right now in 2021, there's a new bill that's in place to try and promote this again. And it's a really good opportunity to start understanding the health of communities across your state. The other thing we need to do is address root causes of poor health. So it's easier to look at our quality measures, which is more the pointy end of the stick. You know, did you get screened for cancer? Is your diabetes controlled? But we often think about these root causes. So I was telling you about the care planning study, which is much more grounded in addressing mental health, health behaviors, and social needs. And these are more difficult to address in primary care, but they're critically important. One of the reasons they're important is if we look at what affects people's health and well-being, well, we know everything we do in clinical care is about 20% of this formula. 30% is health behaviors, 40% is social and economic factors, 10% is the environment. So, you know, how do we start having a role in these other areas? And what is the role of primary care? We have a lot of thinking to do with that. So back about 7 or 8 years ago, we tried asking our doctors to screen for mental health and social needs. And in Northern Virginia, which has a number of the more affluent communities in the state, or actually in the nation, we found 70% of our patients had some type of a social or mental health need. Now, if you look just at the core social needs, we still had like 1 out of 5 patients with basic social needs like unstable housing, trouble with food, trouble paying for their medicines. So these are big issues that we see in any primary care setting. And one of the things that happened when we did this is that many of our doctors were like, well, why are you asking me to ask about these things? How am I supposed to help my patient with their housing and their finances? I don't know how to do that, and I don't have resources to help with that. But at the same time they said that, they also told us for 50% of the encounters, when they saw people and knew this information, they did something different. So it might not be that they actually helped the patient with their finances, but they did things like took more time with the patient, did alternative strategies for testing to reduce costs, or having a better understanding of where the person was coming from and not just thinking that they were being non-compliant. If your system is like ours right now, our health system is promoting the social wheel in Epic and saying, oh, we got to get every doctor to ask every patient about their social risks, and we got to populate that wheel. If I put on the hat of the U.S. Preventive Services Task Force, we actually only have 2 screening recommendations for social risks. One is for intimate partner violence for women of reproductive age, and we recommend doing that. That's a B recommendation. But when we looked at screening for neglect and abuse in older and vulnerable populations, or child maltreatment, we found insufficient evidence that doing that changed health outcomes. Doesn't mean that they're not important topics. It meant that when we looked at the evidence, we didn't find evidence that interventions by finding this through screening changed health outcomes. Now, just recently, there was an updated paper from the U.S. Preventive Services Task Force, and we really looked at how the task force is addressing social risks. And one of the things that I was excited to see when we reviewed everything is that of the 85 recommendations, 57 of them actually include social risks in the recommendation. So it might not be about that social risk being a preventive service, but it was a lot of details about how social risks change a person's risk for a different condition, or how it might influence how the intervention is delivered, or other factors we might need to think about. And those might be more important, although the task force is more and more looking at social risks as a preventive service. I suspect that food insecurity might be one that the task force takes on sooner rather than later. But I think that we have a lot of work to do to figure out what is the role of primary care in dealing with this. Here's another paper from the task force that I think is really important, and it brings up this other issue about access to all, and this is equity. And we know that there's a tremendous amount of inequity in health and outcomes. And so this is a paper where the task force talked about how we were going to be viewing equity, and very specifically how we were going to address systemic racism and its influence on health and outcomes. And one of the things I found over the past 7 years on the task force that actually made me very discouraged is that with every preventive service, there are always groups of individuals who are suffering more and have worse outcomes related to that condition. Most often it's Black communities, but it also includes Hispanic communities and American Indians, Alaska Natives. There's even an example in hepatitis C of white rural communities. But throughout all of our recommendations, there are the more historically marginalized and medically underserved populations have worse outcomes. Here's some data that scares me. So this is looking at the chance that a Black man is going to have a heart attack versus all men of all races. And you can see it's double to triple the risk. So a 50 to 59-year-old Black man has a 63% risk of a heart attack or stroke in the next 10 years compared to all other races, which is 30%. And if you look across quality reporting, ARC found that compared to white people, Black people had worse care on 76 of 190 quality measures. And similarly, Hispanic and Latino people had worse care on 58 of 167 quality measures. So the task force put together a number of actions, starting with thinking of race and ethnicity really as a social and not a biologic construct, trying to promote diversity. There's a big evidence review that they commissioned, and that'll be coming out on the task force website shortly. That's talking about what can health systems and what can primary care do to improve equity and address racism. And then the task force is iteratively trying to use these methods in making its recommendations. One example that just recently came out was a recommendation on colon cancer screening. And I think all of you know the task force lowered the age from 50 to 45 to start screening. And we looked really closely to say, well, should we make a different recommendation for Black people who have worse outcomes and are more likely to die from colon cancer? And we didn't find evidence that doing something differently would change outcomes. But we did find evidence that Black communities have reduced access to screening, reduced quality of screening, delayed times from diagnosis to treatment, and not as good quality of treatment. And in the modeling work we did, if you adjust for all of these things, the mortality difference goes away. And I think that this is clear evidence of systemic racism, and it tells us that we really need to be trying to think about the systems and the communities that we're caring for, and how do we address these inequities. So the third recommendation is around training primary care teams where people live and work. And the actions here were about diversifying the primary care workforce to make sure that they are more representative of the communities that they serve, but also diversifying in terms of the disciplines of the primary care workforce. And then, working through these different funding levers to try and increase funding for this interprofessional training. And I think a big implication of this is we need to be thinking about training a very broad workforce. We need to be thinking about training this workforce in the communities that they'll serve. So these are some flyers from the Family Medicine for America's Health, really talking about the workforce and its role with public health, which is, this was 2015. So this was important back then and even more important now. And that building the strong primary care workforce and family medicine and primary care's role in this. But we need to think broadly about training the entire team. I want to talk for a moment about digital health information technology. And so there was a recommendation about really trying to get digital health to better align with primary care and to make sure that it's helping to better serve patients and families. And, you know, one of the things I've learned over my years is if you want to get clinicians to complain and you want to raise their blood pressure, just ask them to talk about their electronic health record. There's nothing more fun than complaining about our electronic health record. There were two very big goals in terms of recommendations. One was the next phase of digital health certifications. You know, Meaningful Use did a lot with promoting adoption and implementation, but it really didn't promote the types of systems that I think we need in primary care. And so it's about a digital health certification that's more about how the systems function. And instead of holding clinicians and health systems accountable for how they're implemented, it's much more about holding vendors accountable. And then the other thing is to make sure that comprehensive aggregate patient data is accessible. So many of us spend a lot of time trying to pull together our patients' information, and it shouldn't be that way. We either need a functional real-time health information exchange to give us everything on a patient that we need, or we need a common database where all of this is stored. So we talked about what does a better world look like for clinicians. So digital health should make finding information easy. It should aggregate it all. It should automate our work. It shouldn't cause extra work. It should do it for us. It should make the right care at the right time easy to deliver. It should add to our relationship with our patients, and it should bring teams together. And then what does a better world look like for patients? It's anticipating decisions and needs. It's getting people information to engage them in their care. It's trying to help them participate in medical decisions and do this outside of encounters. And it's supporting them in making care plans and sharing information across team members to make care easier. So the National Academy report basically said, you know, digital health does four basic things. It collects information, it aggregates information, it analyzes information, and then it applies information. And, you know, what we need a lot of is more sense-making content, and we need things that kind of automate and make the right care easy to do at the right time. On the other side of the screen, this is some models we've been doing about, well, what would these systems look like for patients? And at least on our end, for making digital health more patient-centered, we've been talking a lot about combining patient-reported data, things like values and beliefs and preferences and behaviors with their clinical data, applying it to guidelines, and then telling people in lay language what it means. And then from that information, letting people be able to act on it. So let's talk about the implications of what does this mean for primary care. So the first I'd say for you is get ready for apps in your electronic health record. So our smartphone, they're nice and everything, and they work well, but probably most of the functionality in it is all the apps that you have on it. And there are new FHIR-based standards that allow for easier transfer of read-only information. And so we're starting to see apps. And in Epic, there's a nice app orchard. And I think we need to be looking to adding these functions onto our systems to make them work better. This is something we've been working on for more than a decade now. It's a patient application to help with their information called My Preventive Care. And we've been using this routinely in care to kind of translate information and take that little care gap that you have that they might see in their My Chart and really explain to them what it means so that they can act on it. The other implication I would say is we should be thinking about how can digital health help us to automate care outside of encounters, to engage them in decisions and reduce clinician workload and make time together more productive. So almost all the research that I'm doing now when we're working with digital health, I'm trying to have one of our outcomes being reduced workload. So I don't want to just show that I'm improving care. I want to show that I'm making lives of clinicians and patients easier. This is one of our models for cancer screening decisions. There's lots of decisions that are shared We spend a lot of time talking about it. And we've been doing things with our systems where we can find people coming in for appointments who might be making a decision, sending them information before the visit, getting them to kind of reflect on where they're at with their decision and how comfortable they are with their information, and then getting that to the doctor before the visit so we can jump right into the discussions that we want to have with people to make visits much more productive. And these are just some screenshots on this care plan and how we might go about it for something like prostate cancer screening, and asking patients about where they're at with their decision and how they might act on it. So I'm going to make sure that we have some time for some questions, and we're coming to a closure here. The fifth recommendation was about ensuring high quality primary care and that it's implemented. And this is about putting leadership in place. So it was having a HHH secretary on primary care. And if you get an opportunity to kind of advocate on a national level for folks, this is something to be pushing for, that we've got leadership in our Secretary of Health who is promoting primary care and is a primary care czar in effect, and making sure that primary care has what it needs. It's about a primary care research office at NIH. It's also about funding the primary care research at ARC. So ARC is actually charged with funding primary care research, but their dollars are allocated to patient-centered outcomes, safety, information technology, and not really primary care. And yet it's the only funding agency that's looking at the delivery of healthcare systems. And then really bringing together the different societies and consumer groups to promote primary care. This is the scorecard. How do we track? Are we making and succeeding with the things that we need to do? And the scorecard for these different 5 aims was to build on data already available. So payment is easy. What's our primary care spend? We have to watch how you define primary care spend and make sure it's being defined right in each state, but that's an easy thing. And access to care can be number of people seen and factors like that that are collected. I'll share with you, digital health had no measure, and that was one of the reasons we said there needed to be that next phase of accountability. I know in our health system, we just switched electronic records again for the 5th time now in my group of primary care practices. We're on Epic, been on it a year, and the health system that we joined up with has a terrible instance of Epic, and their dashboard is just awful. But we're working to try and create actionable dashboards. It's the same thing as this concept of a national scorecard. We need these local scorecards. And what we're trying to do is really make clear what the quality measures are that we're trying to promote as a primary care entity, and then have on our dashboard where any clinician at any time can see how they're doing with each of these different measures. And then they can click on these measures and they can actually reach out to patients and send out mass messages to try and act on their gaps and the types of things that they want to try and improve. So there's a lot of opportunities here that we can do to kind of improve what we're working on. So I'll just kind of conclude, and we can turn to questions and such with, that I really think it's time to start treating primary care like the common good that it is. And I don't think we have been, and that's something that we need to advocate for. This is a societal good and a resource that we need to build and promote to ensure the health of our communities and to promote equity. So that's probably a good time for me to stop and see if there's some questions here. And I see we have one question already that's typed in about from Rodolfo: building upon or attempting to improve the reach and effectiveness of primary care in the U.S. seems to assume that delivering care based on a for-profit model is feasible. U.S. healthcare costs are much higher than other developed countries, perhaps because profit-driven services are rewarded over public health in general. Is the elephant in the room medicine as a business? Yes, absolutely. So, I mean, in addition to the data that I showed you about not spending enough on primary care, if you ever go on Google and just type in this, how much does the U.S. spend on healthcare versus social services? There's a graph that compares the U.S. to other developed countries. And we're upside down. Other countries, the US, we spend 17 to 18% of our healthcare dollars on healthcare, and we spend 7% on social services. And I'll tell you that social services includes education, which is terrible to think about. And most of the other developed countries are the exact opposite. They spend 17 to 20% on social services and 7% on healthcare. So we do need to kind of tackle the profit. And that was some of the reasons that the committee was really saying we should switch from the fee-for-service visits and talk much more about these hybrid and where it's about being funded and resourced to care for communities. And that's where looking for value on our dollars is important. And I see the question about what recommendations you have for approaching payers to begin partnerships and collaborations. I'll tell you that our governor's task force has been tremendously helpful, and it includes healthcare systems, primary care clinicians, and the payers. So our governor brought these groups together in kind of a fair arena and everything. We talk very different languages. So, the payers are speaking right off the bat about trying to reduce spend and other types of things. They're saying that they're doing a lot to promote primary care, but their ideas of it are not what our clinicians are talking about. So some of it is just starting these conversations and bringing people together.
Kind of along those same lines, I wondered from like a resident's perspective or early career physician's perspective, my assumption is like we can join our associations like the Texas Medical Association and things like that in order to help advocate for these things. But is that association you just mentioned something that physicians can join to kind of help with building the numbers of building those relationships? Like, I guess, how can we like sign up to get actively involved and continue to stay involved?
That's a great question. And the short answer is there's a lot you can do. So I think signing up for different state agencies is important. I know in Virginia, we have our Virginia Academy of Family Physicians, and they're very active, and helping them helps move things forward. The other thing I've learned more recently, just from my task force work and other things, is that it's really easy to get in and to talk with your legislatures. They want to talk to clinicians, and they want to talk to clinicians even more now with the pandemic and everything. And you might only get in and talk with a staffer, but the staffer is actually the person who makes all the decisions and moves everything forward. And so there's easy opportunities along those lines. The other thing, though, you can do is just talk with patients and other people. And I remember I used to never talk politics with my patient, and it's an area that you got to be a little bit careful. But I remember back when the Affordable Care Act was trying to be pushed forward, and I had one of my patients who had struggled for years to get him his insulin because he couldn't afford it. And he came in to me complaining about the Affordable Care Act. And I just kind of snapped, not at him, but just internally, and saying, well, you're the perfect person for this. This is here to help you. And it was really interesting because it was the only time I ever, for the first time, I started saying, I think this legislation is going to help you. Let's talk about this. And that made a difference. And then the other thing that even just makes a difference is trying to design your system in ways that they should be designed, and then telling the stories about that. So, I think as physicians, we get to hear things about people's lives that you don't normally hear. It's a real privilege. And we can talk about how these different things affect people, how not having health insurance is impacting people. And that can be very powerful. So being able to talk about and share those stories, obviously you got to protect HIPAA and those things. But in the position that we're in, it's a real opportunity to give a face to why we need some of these things to make change.
Any other questions or comments?
Dr. KRist, this is I'm Ashok Kumar from one of the primary care clinics. I just wondered, the political systems we have in different states, obviously, when you look at it, it is quite evident that some states are better than others for access, for providing social services and stuff like that. And I felt a little bit easier when you brought up that, yes, it is difficult for us to talk about politics, but you did mention your patient who needs that help, and that's the same patient who doesn't understand what Affordable Care Act is. So same way, there are so many things we have. I mean, this report is full of excellent information, and your presentation has, made it much easier for us to understand, like in the periphery. But how do we tackle this main thing of how even the doctors, if physicians, even primary care, family medicine physicians, when they do not have the same unified opinion about healthcare being a right rather than a privilege. So maybe we should start educating our own people, our own primary care family doctors all over the country, 100,000 strong, that this is the way to go to provide this. I don't know, do you have any ideas to educate our own people?
Well, yeah, I mean, I think everything that you said is really important, and I agree with everything. I'll tell you that in Virginia passed Medicaid expansion under a Republican legislature, which you wouldn't imagine would normally favor Medicaid expansion. So, there are processes for that. I think your point about kind of, baking this into our education, I think is very important as well, and highly useful. I think there's a lot of things that we kind of fundamentally agree with. Whenever I talk with medical students, or we interview residents at our residency, and we say, well, why do you want to go into this? I mean, everyone says the same thing. They want to help people, right? I think we're all very bound by some common beliefs and common interests. And I think if we can think, back to some of those core principles, I think that if we can kind of fall back on data and evidence and look at where things make differences. So, having strong data that shows that primary care and access to primary care improves the length of life and improves equity. I mean, most people want to live longer. They want to be healthier. These aren't hard things to advocate for. So I think trying to kind of focus in on some of those core principles is very helpful. I mean, how you get there, there's a lot of different ways. And that's a place to really be thinking about kind of different paths and innovation and how we might do things. And that's where even in our little microcosms and on our grassroots level, we can start making changes and talk about the changes we're making and show people the impacts they have. And that includes education. And I think it can start with, certainly we should be doing this in medical school and in residency, but, you can argue thinking about basic rights is an important thing throughout education.
Yeah, thank you.
Any other comments or questions? Well, Dr. KRist, you have been very helpful in illuminating, and we are thankful for your inspiration, and we are renewed in our effort to move forward. I want to take a moment to recognize someone who is on the call. We just got elected to be a Pisacano Scholar, Garrett Knies. So Garrett, if you can turn on your camera, it will be great, because we want to applaud you for that recognition. And Dr. KRist knows about that program, and it's a great, very prestigious award. So congratulations, Garrett. All right, well, there he is. We're excited.
Hi there. Thank you all so very much. But I do want to pass the torch back over to all of you who are watching, who have mentored this opportunity. It's a moment to congratulate everybody with the Department of Family and Community Medicine and everybody at the Long School of Medicine who worked so hard to inspire students to become the champions that we need for primary care. and to pursue the excellence in partnership and camaraderie that the Piscano Foundation is all about. And so I do want to continue to reiterate that this is a moment for all of you to celebrate an incredible job of mentoring me and supporting me through innumerable and invaluable experiences. So thank you all very much. And thank you very much, Dr. Haim.
And a reminder that we have one more event tomorrow morning. Dr. Andrew, you want to tell us about it?
Well, Dr. KRist will be providing an insider's perspective to the USPSTF and those recommendations and where they come from, how they're developed. Should be a great session with the students. Certainly others are welcome to attend as well. So we're looking forward to it.
Well, thank you again. Bye-bye.
Carlos, if I might be permitted,
sure, of course.
I did want to share one of these with our presenter. So Dr. KRist, if you were ever in the military or associated with the military, you know that the units, they have their own coin. So we have a coin from the residency. I appreciate you teaching us about leadership and about the future of medicine. So we'll be sending you a copy of the highly sought after, seldom presented, but always treasured Family and Community Medicine Challenge coin.
Yes.
Thank you very much. I'm very honored to be here today, and I look forward to having that coin. That sounds, be in the club. That'll be great.
Thank you again. Bye-bye.